Our first speaker is Professor Yasser Abu Talib. He is the Professor of Obstetric and Gynecology at Shams University, and he's the chair of the Egyptian RCOG Representative Committee. And he's, of course, a fellow of the Royal College of Obstetric and Gynecology, and he's examiner at the same college. He's going to talk about AMH. Is it a misleading ovarian reserve marker?
Good. Okay.
Professor Yasser Tota.
So, good afternoon, everyone. Actually, I know it's 4:30 and everyone maybe won't sleep or something like that, especially after lunch. However, I'm very glad to be here between friends, sisters, and brothers as well. In the name of the Royal College and the Egyptian Representative Committee of the Royal College, I would like just to thank you very much for your kind invitation. Dr. Abir, Dr. Mazen, Dr. Meher, thank you very much, and looking forward to have more cooperation with your committee and your activity. We have been working together over the last 2 years since I was elected as a chair of the Royal College in Egypt, and we have lots of production of scientific material online. So I'm very glad actually to be here to present my country and my Egyptian Representative Committee, and as well to share such a wonderful, respected Congress. Today I'm going to discuss a very important issue. It's anti-Mullerian hormone. Maybe 10 years ago, I discovered that anti-Mullerian hormone become a very novel or a very important factor for everyone. Even the porter, even my porter, kept asking me about the AMH, my sister, my brother, and everyone meet me. And if I have one of my patients come to my clinic to assess her, and I haven't got the chance to write to her AMH, her husband phoned me immediately to ask about, where is the AMH, dear? So I decided actually 10 years ago just to check what's AMH and is it important or not. The point is, everyone used to ask for AMH, and based on that, lots of doctors started to discuss and have a sort of communication or counseling with the patient if they have very low AMH, telling them that most probably it will be difficult to become pregnant, which is an awful thing. So over the coming few minutes, I will try to explain what's AMH and how can we use it and its use. Actually, as I said, in the year 2012, Kelsey and his colleague in the human reproduction said that AMH is the most sensitive marker of the ovarian reserve and the first one to be altered in aging. Let me to say that, what's AMH? AMH is nothing except a protein binded to carbohydrates or sugar. So it's a glycoprotein structure coming from a special generation of material called transforming growth factor. So it's actually a growth factor. Let's go for the normal physiology and anatomy of follicular growth or sperm growth as well. Both of them are equal. For ovum growth, it starts by 3 inactive and 2 active stages. The 3 inactive stages is the primordial follicle, followed by primary and secondary one. And it's in the quiescent phase. Its surface area is less than 6 millimeter. So it doesn't respond to FSH. Why? Because the number of receptors might receive FSH is very low. So it doesn't respond, and it will keep this follicle during this cycle quiescent for the second one. Meanwhile, some of them will grow, reach to the stage of pre-antral and the antral follicle. It's now 6 millimeter or more. At that time, it will respond to FSH. As a result of that, it will produce what's called anti-Mullerian hormone during this cycle. What's about its value? It will stop folliculogenesis in this cycle. So instead of using thousands of follicles, the selected one, who are 2, 3, 4, or 5, something like that, will keep growing, producing anti-Mullerian hormone, which stops selection or encroaching or taking more follicle with them. So it will keep reserve for the coming follicle. So as a result of that, it will stop folliculogenesis, stop estrogen production, and keep the follicle less than 6 months. Everyone knows that anti-Mullerian hormone is nothing except evaluation of the ovarian reserve. Here is the fact, it's not. Why? Because ovarian reserve is composed of 2 components. The quiescent part, the inactive part, which is the primordial, primary, and secondary follicle as well, beside the growing follicle. If we know that anti-Mullerian hormone is produced by the growing one, so it means that anti-Mullerian hormone does not represent the full concentration of follicle inside the ovary. It represents the active part only, but not the whole part. So it's inaccurate to say that anti-Mullerian hormone reflects the whole storage system of the ovary. That's number one. What's about the story of the AMH? It's a very simple story. Starting actually from intrauterine life, while the baby is 36 weeks, they start to produce what's called the AMH. After being a child, it will become detectable in very small amount because the ovary doesn't work till now. At the adolescent, it will reach its maximum at 25 years. Then it decline gradually till 35 years and decline more quickly till the age of menopause, which will become a very native form. What's surprising, what you must know, that to standardize and say that AMH is that, so you have to say that AMH is stable all the time. But going through the literature, year 2011 in the human reproduction, a publication said that the different level of AMH different completely with age. 25 years, it's 3 nanogram, which is the maximum. Then it started to decrease every 5 years by about 1 or half nanogram per ml. Let's have a look to the year, the age of 35 years. Between 35 years and 40 years, it will decrease by about 0.1. At 40 years, it will decrease more, but 0.2. What does it mean? That AMH, it's age specific. Is that all? No, it's another problem as well. It's yearly decrease. So, what we said actually, it's not reflecting the total storage of the follicle in the ovary. That's number one. Number two, it's different with the age. With increased age, it will decrease gradually. And as well, every year, not every 5 years, it will decrease gradually. Is that all? Let's go through another big problem. It's fluctuating. If you measure AMH, between cycle and cycle, it will differ. Between month and month, it differ. But let me to give you a very big boom. If we measure AMH at the luteal phase, it will differ completely between measuring its level at the same cycle, between the mid-luteal phase at which selection of the oma occur, and between the mid-follicular phase, which maximum increase of the FSH and the AMH increase. And E2 as well, when it starts to produce, the AMH starts to reduce in size. in amount. So it's markedly fluctuating. So if you measure the AMH and find it 10, for example, with the menstruation or before menstruation, and measure it with mid-luteal phase, you might find that 10 become 3. So it's markedly fluctuating. The rate of fluctuation might reach to 20% up to 136%. So it's markedly fluctuating. You cannot guarantee is it right or wrong what you measured actually. Add to that, we have 4 ways to measure the AMH. The oldest one comes from France, it's IPC, measuring the antibody against anti-Mullerian hormone. And the second one is coming from Texas, it's DSL. But both of them got different results, completely different from each other. That's why from California come the new test using ELISA. Is it good? No, they found that it's not that good for prediction of the proper AMH, and the most recent one is automated one with the results of during 18 minutes with sensitivity 10 times better than the ELISA. What does it mean? According to the place what you used to do your investigation, you will have different results. So variability of the results cause different in the results as well, and confusion. Is it definitely right or definitely wrong? Another booming. Do you know that the best time to measure AMH, 8 o'clock in the morning? And the problem is, if you collect the blood, you have to separate the plasma and measure and use the machine to measure the AMH immediately. Why? Because if you collect the blood and you separate it and keep it in a temperature higher than -20 every hour, will cause falsely increase the results of AMH. And the usual thing to send the patient to go to the lab, collect the blood, and keep this blood till he collects as much as he can, because he cannot run the machine, which costs lots of money with 1 or 2 cases. So we are expecting to have false high results. Is that all? And this is the third booming. If we are going to rely upon the AMH, so we must have an agreement that nothing will affect its level, right? Am I right? So my hemoglobin is 13. Dr. Abir's hemoglobin is 13. If it's measured, so it's definitely, I'm 13 and she's 13. So definitely, we have no anemia anymore, right? But we discovered that we have lots and lots and lots of factors that might increase the level of AMH falsely or might decrease it as well. And this was published in the magazine of metabolism and endocrinology in long time ago, 10 years ago. It's not recent one. Age, as we said, reduce it. However, PCO associated with high level of anti-Mullerian hormone, this is acceptable, no problem. But if we add that anything might affect ovarian function, include hypothalamic problems, using of LHRH analog, using combined oral contraceptive pills, smoking, decrease of weight, all of these factors might be associated with falsely reduction in the amount of AMH. Not only that, but sleep, increase it. That's why we prefer to sleep and have it in the early morning. Ovarian cyst, especially if you remove it, it will decrease. And surprisingly, folic acid, DHEA, and the most recent thing that we started to describe it for everyone, even for us, it's CoQ10. ده الموضة اللي طالعة الأيام دهيا. Okay, and melatonin. And you know melatonin, it's a recent drug which will help to sleep, especially for women. We have material, put on cacao and drink before sleep, and it will induce. All of these factors will affect the level of AMH. So it's unreliable results. And let's go. Based on that, I tried to find what are the uses and the value of use of AMH. It's very good predictor for prediction not of pregnancy. It's a very good predictor for ovarian response, which is unrelated to pregnancy. If you have a level between 0.1 to 1.6 in a sensitivity of nearly 90% and specificity 100%, it means that unlikely to produce more than 4 eggs. So it's counseling. If you have this, okay, you will become pregnant, okay, no problem at all, and let's go for induction, but put in your mind during counseling that no more than 4 eggs. Even you might have no eggs at all. Okay, so we can predict cycle cancellation, and it was estimated according to the assisted reproductive technology, SART, we know SART, that if we have a low AMH between 0.1 and 1.6, the cancellation rate for the cycles will be nearly 50%. What's about overproduction of the ova? If it's more than 3.3 up to 5, the high production of eggs, more than 10, and the risk of ovarian hyperstimulation will be predicted in a risk of sensitivity, 90%, and specificity, it's 94%. Sensitivity include the patient. Specificity excluded, so unlikely to occur means. But put in your mind that it's poor predictor for the success of the IVF at all. If you have low value, okay, so it's unpredictable, but the age is predictor. And what's about the implantation? Let's have a human reproduction by Idiot and the year 2014, who found no relation between implantation and low AMH. And what's about ongoing pregnancy? In a meta-analysis including 1,008 patients and published by Boer in human reproduction, found no relation at all. And what's about the live birth? If you have a low AMH, so the live birth per cycle, according to SART, will be 9.5. So let's have an agreement that denying infertility treatment based on AMH alone is not advisable. مش حلال، حرام فعلا اللي بيتعمل ده. وبالتالي it has a limited predictive value for fertility. So the question is AMH of great value only for fertility and for predicting the ovulation rate? No. It has other values that we use to do it. Number one, if you have high FSH, 50 and 60, never ever to tell the patient that, I'm sorry, you are menopausal. She will get her divorce immediately. And after that, she will return to normal. It's called resistant ovary syndrome. The only thing, if you have high FSH, ask for AMH. And me, myself, I saw a case back in England a long time ago with high FSH, and we give her cyclic hormonal replacement therapy, and we discover later on that she's pregnant after telling us that I have some sort of irregularity despite taking cyclopregnanolone. And we discover that she was a resistant ovary syndrome and become pregnant. And the most recent advances in the American College of Gynecologists in the year 2000, just a year ago, that it's now used for cases with cancer breast. If you have high AMH, more than 10, so never ever to rush and remove the breast of the lady, but give her chemotherapy. What chemotherapy? Anti-hormones. Not chemotherapy with the side effect. What's anti-hormones? We know that Nolvadex and so on. And recently, just a year ago, FDA approved a special type of hormones, which is hormone replacement therapy with a good effect, might be used with cancer breast because it has, at the same time, material with anti-estrogenic effect. And another thing, material of estrogen has a very good effect on the menopausal manifestation and bones. So ladies and gentlemen, allow me to introduce our friend. AMH is inaccurate measure for ovarian reserve, age-specific, yearly decreased, fluctuating level, unreliable test, lack of standardization, false higher level if we leave it for 1 hour outside the fridge, limited predictive value for fertility. So my advice is, this is take-home messages. Never ever to rely upon AMH to say that she's fertile or not. That's number one. Number two, if you wanted to use it as a predictor for ovulation induction, do it every time you are going to introduce or to induce the lady, not once. And never ever to rely upon once. And tell her that your capability to produce ova is a little bit low, or your risk to produce high level of ova and ovarian hyperstimulation is that, and the cancellation will be 50%. Ladies and gentlemen, thank you very much to listen to me, and if you want to ask any question.
Thank you very much, Professor Yasser. We have time for a few questions. Dr. Abir.
Yasser, I can't thank you enough for what you have brought here in front of all the audience. AMH is misused by all our colleagues in their practice. Really, really.
It's not here, it's all over the world.
It's all over the world. The lady comes 23 years old, regular cycle, عاملين لها AMH, she's not married, بتطلع لها AMH واطي، بتيجي بتعيط تعيو امها، okay, انه انا مش راح اتجوز, I will not have babies. Why did you do it from the first place? It has no regular cycles. There is nothing wrong with this lady. It's not a routine practice to do the AMH with all the factors that you have advised us. It's there or not there when you do the tests. الإشي الثاني, AMH should never be used to say this lady is going into menopause or not. بيعملوا AMH level بقولها بعد شهرين بتقطعك الدورة الشهرية، بعد 5 أشهر بتقطعك الدورة الشهرية. It does not reflect at all the age of menopause or POI or early menopause. فيا ريت هذه المسج توصل لكل الأطباء. We are misusing AMH in our practice. The IVF doctors, they have the role, plus the age, plus the weight, in using it as a predictor for their success rate. بس مش عليها أنا أجي أقطعها. أنا في مريضة عندي قالوا لها مش رح تخلفي low AMH متجوزة جديد. She had 2 babies till now على AMH 0.1 nanogram.
Thank you, thank you.
فيعني I can't thank you enough.
I remember well that cases with low AMH,
Dr.
never ever to rush and start IVF for her, because she will become pregnant the same if she is younger than 37 years. So no problem at all. One of the predictors. I agree with you completely. I agree. But remember again, AMH is produced from the active part. على فكرة يا جماعة، في حالات بتيجي ال FSH بتاعها 50 و60 وال AMH بتاعها 0.1. تعالى بعد شوية أو في السايكل الثانية عيد الكلام ده. هتلاقي ال AMH نزل والدورة نزلت لوحدها and still there for, especially in the perimenopausal area. Why? لأن ربنا سبحانه وتعالى في الأوفري موزع البيض irregular completely. This area is empty, so ما فيش ovulation. This area has 1 or 2 ova, اثنين اللي يطلعوا. This area has 6 ova, and so on.
Dr. Adwan.
Thank you.
تفضل يا فندم. تفضل يا فندم.
So how can we diagnose premature ovarian failure, not depending on low AMH and high FSH? How can we diagnose premature ovarian failure?
High FSH, very low AMH. It means that FSH reflecting the function It means that the ovary is not responding. The question is, if the ovary is not responding, does it mean that there is no ova, so it's menopause? If there is ova inside and not responding to FSH, it's resistant ovary syndrome. And we sort out by measuring the AMH. If the AMH is good, it means that resistant ovary syndrome. And let's come for the treatment. There is no treatment. You are going to give her replacement therapy. And as I said to you, when you give her cyclopregonova, don't give her non-bleed form. Bleed form. Because you will discover that she returns to normal when she starts to have irregular cycle. You discover that she responds again. But the counseling is very important. Just tell her that sooner or later, you will get your ova again starting, and the ovary will work again.
Thank you very much. I don't think we have time for any other question.
AOI is amenorrhea for 4 months associated with elevated FSH above 25 and done one time. هذا الإشري 2024. You don't have to repeat it. وما إله علاقة AMH. This is the new definition for AOI.
شكرا للجميع. Allow me to present our next speaker, my friend and mentor, Dr. Hani Fawzi. You all know Hani is a seasoned global health leader with over 35 years of experience in obstetrics, gynecology, public health, and international development. Since I knew him, he was a consistent voice for principled governance and servant leadership. He will talk to us today about the essence of leadership, discipline of effectiveness.
Thank you very much, Dr. Omar and Dr. Shawgi. To start with, Bismillah ar-Rahman ar-Rahim, I'd really like to appreciate and thanks the Society, the IRC, and the Jordanian British Obstetrics and Gynecology Society for the invitation. I feel I'm just at home. My dear colleagues, I can see from my title that I'm retired. So I'm not going to talk to you about anything clinical. Perhaps it's an opportunity for you to just relax. There is nothing I'm going to talk about that has got evidence or has got science or quotations from the literature in any way or shape. So it is something that each and every one of us has a pie in this and at stake, definitely. So leadership is a word that echoes in every corridor, in every institute. Let's begin by mapping the foundational concepts that I'll be talking about. I'll try and touch on some definitions that hopefully will clarify when we come to the messages that we want to pass on. And in that context, I'll try and describe it is the disciplines of effectiveness. What is a discipline? What is effectiveness? What are paradigms? What is what I call 4 chronic problems that face us in our leadership roles, and then perhaps come with some conclusions about the essence of leadership. And you can see I'm going to use a human mind, with a body, with a heart, and a spirit. And I hope these 4 arcs remain with you as we speak, but perhaps after the lecture. Okay. Samuel Smiles, a physician, an author, a Scottish physician and author, had written these very profound words. I'm not going to read it because I trust you have already read this by now. Well, I'd really like to draw your attention. Our destiny, that's where it ends. And where is the beginning? So a thought. Everything starts with how we think. And it is these thoughts that determine our destiny. I talked about effectiveness. What is effectiveness? And I'm sure I have very poignantly not used the word success, not used the word efficiency, another term that is sometimes mixed with effectiveness, because these two might be confusing. But perhaps let us just equally define what is a discipline to start with. You see 3 intertwined circles. One relates to the knowledge, what to do, why to do it, the skills, And then perhaps a very third important element. I'm sure you expected me to say knowledge, skills, and attitudes. That's how we're taught in medical schools and throughout our training. Rather than an attitude is a desire. The intersection between these three parameters, our knowledge, our skills, and the desire, the passion that you want to do what you know and how to do it, this is what a discipline is all about. When it comes to effectiveness, it's really here defined as the essence of it being you get the superb results, outcomes that you want to produce, and here I would call this production today, and even better, tomorrow, in the future. There is a PPC ratio that we really want to create that balance with. And perhaps to drive home what this production and production capability is, you might remember these wonderful stories of Aesop's and fables and fairy tales. I'm sure we have had it at school. Once upon a time, a poor farmer had a goose that laid him eggs. He took them to the market, sold them and exchanged them for some goods. The following day, the same happens. One day, to his surprise, the goose has laid for him a yellow, bright, shiny egg. Quite surprised, went to the market. It was heavy. Indeed, it exchanged for him a lot more money, and he could buy more goods. He went back home. His wife and children were ecstatically happy. The following day, to his surprise, another golden egg. Goes to the market, the same happens. The third day, the same happens. What goes in his head? Wow. If I go and kill this goose, I'm going to find all these massive eggs. To sell them all once and for all, I'll be rich. And I'm sure you know the rest of the story. To his surprise, his greed took him nowhere. This is what we're talking about, ladies and gentlemen, about production and the production capability. The people that we work with, the production capability. The team that we work with, what do we want out of them? And let's just keep this thought of what effectiveness is all about. You can see that here is the roots. That's where genuine effectiveness starts. It's our character. It starts within ourselves. But unfortunately, what everybody sees about the person is their personality. Why is it so much above? Why is it that people see this and think that this is what it is all about? The character of a person, the character of a leader is unseen, especially in early relationships. But I don't need to remind you that if you have strong roots, you have got strong personality. And that's what people will see. Let us perhaps keep out back of our minds the maturity continuum that happens to all of us. We start with being depending on someone. We reach a stage we become independent, and we think that that is the end of the world. Whereas, just take an example of a child or even a trainee becoming a consultant, you become independent. There is one higher stage of maturity in that respect of being interdependent. And it is this when you start working in teams. And here is where the role of the leader comes to shine. It all starts within. Every discipline we're going to be talking about not only starts with individuals, but has this ripple effect. It affects the organization, and it affects the team in between that you're working with. Effective individuals make effective teams, and in turn, effective organizations. After all, is it not the case that an organization is as effective as its individuals within it? Keep that thought in your mind. It all starts from inside out. We hear this phrase, a paradigm shift, so often, and I'm sure I have been in this audience for this morning and afternoon, and I've heard this, we need a paradigm shift. We're looking for results, and we talked about effectiveness, and this is the results. I'm sure you would all appreciate what determines the results we get at work or at home are our behaviors. If we don't like what we're getting, we're going to change our behaviors to try and improve it and change. If you carry on doing the same thing and expecting a different outcome, that's what Einstein labels as being insanity. And indeed, what drives our behavior is the one bit above. The way we see things. Paradigm, I'll describe it in a minute, but let me just give you an example to try and see how this see, do, get. Well, again, a notion that we use a lot in medical education in our training modules, see, do, plan, and so on. You walk into a door, you push it to go, it doesn't give way. You push again, it doesn't want to go in. The door is not giving way. You see the word pull. What do? Your behavior changes, and you're going to pull it towards yourself. And then you can go through. And it is, if you really want an optimum, if you want a quantum leap in results changing, do not work on your behavior, work on the way you think. And trust me, that is the shortest cut to it. So what is paradigm? And briefly, it's the way we see the world, the way we understand the world, the way we interpret the world. It's our mental map. The way things are and the way we see them is upon us, not exactly what it is that we are doing there. So developing a new discipline and habit is more than doing things differently. It's about seeing things differently. We talked about the door example. You push harder, it won't give, and then you see the sign and you feel, okay, here is a change after I have seen things differently. I want, before we move into the paradigms or the different principles, perhaps explain to you that central element that talks about the principles of effectiveness. So we know that the word, instead of the word see, it's a paradigm. And it's compared to the windows, the way we see the world. When we were very young, our windows were clear. As we grow, we become conditioned by our experiences. Think of an organization. If you have a concept that your workers are, you think they are incompetent, what will you do for that? If that's the mindset that you have, my team is incompetent. The next thing that you're automatically going to do is going to be micromanage them. And then you can only imagine what is going to be the result. I'm sure it doesn't take much of an excitement to understand the mediocrity that we're really going to see there. And then you might feel that this is a self-fulfilling prophecy. It goes round and round. Let me just expand a bit about what the principles are. And here is one example just to share with you in public. We talk about principles like gravity. Regardless of what you throw up, it will come down. That's a principle. Effective people base their paradigms on principles of effectiveness. And let us just take an example of biology, a principle in biology, that simply says that the human body needs nutrients to survive. Principles, dear colleagues, is timeless. In that context, it's not temporary. Did our ancestors require nutrients? Will 10 years from now, 100 years from now, we're still humans needing nutrients to survive? Principles are equally universal. It applies on everyone. Does every human need nutrients or just selected beings? They're self-evident in that context. They're very objective. Looking at them neutrally, independently, external of us, did we make this up about this law of nutrition? Is it not open to our interpretation? Definitely it's not subjective. And perhaps the most beautiful element about principles is that in operation, whether we accept it or not, this is going to be the case that it stays in operation. Several principles, I can share with you a few of them just for brevity of time. If we talk about responsibility, choice, accountability, initiative, being proactive, aspects that relate to a vision, to a commitment, to the purpose that you want to achieve. Begin with the end in mind. Focus, integrity, prioritization, putting first things first. All these elements relate to our victory, self-victory as individuals. And if you want to be cooperative and work interdependently with others, we talk about mutuality of benefit, fairness, abundance, respect, and so on and so forth. Let me translate this in a simple context. How do we see things? A common paradigm might be that this is just the way things are, and there is nothing much I can do about it. That's a common paradigm that I'm sure many of us face many times. Perhaps let us see how a highly effective paradigm could look like. I am free to choose. And I would really like you to stop at the word choose and choice. I'm free to choose, and more importantly, I'm ultimately able to make a response. I'm ultimately responsible for my happiness. To share this particular element of choice and aspects of a stimulus and a response, Newton's third law, every action has an opposite and equal reaction. And there is a gap between when we're hit with any situation, how we react or how we proact. Trust me, it is in this gap that we really have the greatest sickness of our happiness. That's when we start using the elements I talked about earlier, mind, body, heart, and spirit. We can see the self-awareness elements of the ability to examine our thoughts, moods, and behaviors, our imagination, ability to visualize beyond our current experience and circumstances, our conscious understanding whether this is right or wrong reaction, our personal integrity, and perhaps, above all, our independent will, the ability to act independent of our external influences. How do we do things? And I'm sure here you can see the stimulus and response as an example. Let us look at the first line, talks about reactive and proactive. The language, nothing we can do, just the way I am. It makes me made. I'm just an Irish. And it runs in our Irish blood, in our family. The same applies to us in many contexts. It makes me mad. I have to, I can't, I must, if only. Perhaps let us see how that language can change to be more proactive. Let's look at alternatives. I can choose different approaches. Can choose a better response. Choose, prefer, I will. I think you got the message. Another element of it relates to the circle of influence and the wider circle of control. I'm sure if we are reactive, we'll just be focusing on our circle of influence. It leaves us less time and energy to expend on the things that you can influence. Look at the third line, relates to elements that are more about wasting time and energy, and a more effective paradigm. I trust I have made myself clear. If you want to be trustworthy, if you want to be trusted, you have to start with yourself and being trustworthy. Your team have choices in working with you, staying with you. A team working together, or a team trusting each other. Look at the choices that they have. And I'm sure you can go from the bottom. Okay, just move on, agree, surrender, accept. And look at north of the line, that excitement and will that really sort of hopefully opens for us paradigms of mutual contribution, of real excitement, and making definite, genuine change. I have talked about the 4 chronic problems, and I shared with you mind, body, heart, and spirit. Even in the most well-resourced institutions, we encounter persistent chronic issues. But if we carry on leading in these particular perspectives, I'm sure you can see them at the heart of it. Low trust, no clear purpose, misaligned systems, and the talent not unleashed. If we don't challenge ourselves, hopefully, through going this human paradigm, I am sure we'll be doomed to fail. And perhaps the mind map or the roadmap that I've got for this is how you can see for each one, there's going to be a particular perspective of how we inspire trust at the heart of it, in the center of it, clarifying the purpose, aligning different systems, and I'll talk about each one of these in 4 slides, and hopefully we'll just make some conclusions. Let's then talk about the essence of leadership. The first important element we talked about is our mind. Traditionally, one might think, as long as people have a clear job description, they will be fine. The mindset confines individuals to preferred, predefined roles. Let's imagine a shift to a mindset that talks about if a clear and compelling vision exists, people will volunteer their best efforts. Can we see the effectiveness here? Working with a team, it's important that we have a clarity about the purpose. What is the job that we need to be doing together? How does that link to the strategy that we want to be going towards? And perhaps more importantly than these two elements is the concept of the financial, the money-making model, the business acumen, to understand it's a chronic problem. Hopefully, one element of pathfinding as a leader is to really find the job to be done, its strategic links, and the business acumen of the finances going together. So moving on to our body, we talk about alignment of systems. And perhaps here we have a different paradigm that talks about everything is so dependent on me as a leader. Perhaps that is the common everyday sort of mindset. But how would it be more compelling that a leader, an effective leader, will be really thinking of enduring success in creating systems? A system for recruitment, a system for retention, a system for promotion, a process that really guides. And here on the right-hand side, I have put that aspect of the disciplines of execution of any particular point, where you really think of what is it that you want to achieve, and then have clear parameters. What are the lag measures? What are the lead measures? Have clarity about this scoreboard to know where we are at times in terms of our progress, and perhaps once this is achieved, how we have the accountability and move on to the next element of it. The third element relates to our empowerment. And here you can say one paradigm that talks about, I need to constantly motivate my people to get results. Perhaps a genuine leader who is more effective would be on the lines of feeling, my job is to release the talent and the passion of the team. And I'm sure, ladies and gentlemen, you'll agree with me. Many of us have so many talents within the team, but they have not been utilized. They have not been asked for. And in terms, it's that you try from doing it as a leader. It's your role. The essence of leadership is really to empower your team to try and come. And here it's, I'm sure this can be going for longer, but you can see the intersection elements. You found your voice. It's your time to help others find their voice. And as a leader, that is the element, the essence of empowerment. This change emphasizes unleashing talent, where leadership focuses on enabling individuals to find their unique voice, intersecting the needs, passions, conscience, and talents. That is our heart. And here comes my last element of the spirit. And that's where I feel the legacy comes in, the crux, the central element. A mediocre leader might be thinking about, I get things done because I am the boss. It's formal authority. How effective would it be if you utilize an informal authority? I get things done through personal influence and credibility, the informal, the moral authority. And here again, it's an intersection between the character and the competence. And you can see this area intervening these two. That is where the spirit is, and that's where high trust equates to high speed and low cost in achieving goals. Ladies and gentlemen, as part of my conclusion, I'm going to share with you this element of some take-home messages. Remember that leadership is not about titles. It's not about status. It's not the rank that you hold. It's not the office. It's not the role that you're doing. Indeed, it's a choice, and each and every one of us can make to make a difference. The choice to lead change and the choice to ignite humanity. Let's leave here today not just attendees of this wonderful, great meeting, but as champions of change, equipped to transform our perceptions our actions, and ultimately our outcomes. Thank you for your attention, for your dedication, and for your passion.
You promised that we will relax, but this is a very stimulating. Yeah. Any questions to Dr. Hani?
I think either it is so clear or it is so difficult.
Very stimulating.
But anyhow, whatever it is, thank you very much for listening.
Okay, thank you, Hani.
Appreciate it.
Our next speaker is Professor Yaqub Khalaf. He is very well known to all of you, and he was introduced before. And he's going to give us a critical appraisal about IVF pre-treatment strategies. Professor Yaqub, yes, sir.
Thank you very much, Mr. Chairman. I wish I had a wig and disguise my voice, because you must be sick and tired of seeing me. Anyway, it is your destiny, and thank you. Thank you, Dr. Mazen, for asking me to speak 3 times. That's great privilege. Okay, now we are talking about IVF pre-treatment strategy. I will use it as an opportunity for a whistle-stop tours around IVF, and I'll be prepared to answer any question at the end, because I'm sure some of what I say can be controversial. I always take pride in appearing in this photo with the greats, and the greats are not just Bob Edward, but also my mentor, Peter Brody, whom I owe a lot of debt, really, because he instilled in me a lot of what I stand for. And one of the things that he instilled is, patients don't want tests, they want a baby. So try to get to that stage from the shortest possible route. Don't just go beating about the bush in areas that don't add value. And you can do whatever you do for your patient as long as it adds value. And we know in economy there's something called return on investment. You make them make the money, give them something in return. If there is nothing in return, you are wasting their time and their money. The burden of IVF treatment is unmistakable. You might ask, what burden? It's emotional, it's financial, and it's medical. Patients come to the IVF clinic, we count them as another couple who are seeing, but they have been stressing about this visit for weeks. They have fear that whose fault it is. If the man's sperm tests, he will be guilt-ridden. If the woman, she's feel inadequate and fearing for her marital career. And this is an account. I'm afraid she'll leave me because I am the infertile one. I'm afraid they will leave me for someone who can give them a child. We are all familiar with those feelings. The other concern is, I am spending my hard-earned money, my limited money. Will it work? What if it doesn't work? What will I do? All of these are emotions that are gripping those particular couples. Plus the cost. Money don't grow on trees. And those patients or those people will have been saving for this expensive treatment. And they always have doubt, is it worth it after all? If we spend this money, will we get something in return? So what is our professional role? To adopt the right concept, to adopt the right practice, and to have ethics at the center of everything we do. In terms of our concept, it must be holistic. We can't take the patients like bits and pieces. And it must be individualized. Patients, they are not all the same. Their circumstances are different, their biology is different, their psychology is different, and we need to cater for this. But more importantly, we need to prepare them. IVF is a marathon. It's not a sprint. I can't tire of making that statement, because if people are in it for the long haul, they will probably continue and have the resilience. But if they are expecting it to be sharp, quick shot, they will be almost certain to be disappointed. I also have been taught to not lose sight of what is important. Because we talk about preparation. I can tell you how simple my preparation of my patient is. I see a patient who is 28 years old, has been trying for a year with her husband. Her husband had sperm test, but his GP is normal. She had a scan, she was told to have polycystic ovaries. I will only probably do virology screening because it's a regulatory requirement for hepatitis B, hepatitis C, and HIV, and I might just add thyroid function because that's all I need to know. Because from what she told me, the sperm is normal. She will have IVF, not ICSI. She told me has a diagnosis of PCOS. This patient at risk of hyperstimulation, I'll give her decent dose of medication, antagonist, agonist trigger, freeze all. End off. Nothing more, nothing less. And when I start her stimulation, she's 28. I could choose 150 or 2 to 5 and reduce it later. And I see her only 8 days after stimulation. Why would I bring her every day for a blood test? I know the outcome, I know the exit. So it is as simple as that. And that's what I do day in and day out. However, if the patient came having been investigated earlier somewhere else, and she's 40, her husband is known to have azoospermia, or say oligoacinospermia, and she is known to have low AMH, and she is 40. Again, this patient, I might do her, of course I forgot with the previous one, I knew her polycystic ovaries and she doesn't have any issue with the uterus, I may not even do a scan. But with this patient, she doesn't have a scan, I'll do ultrasound scan, make sure the uterus is fine, assess her ovaries, and after that I'll give her decent dose of combined gonadotropins, part HMG, part gonal F, you can debate it, whatever you like, and I will ask her to come on day 9, the first scan. And invariably on day 9, I will know how many days needed before she's ready for egg collection, 2 or 3 days. As simple as this. So it has to be bespoke for the individual couple and not one size fits all. And we need to stay focused on the fundamentals because losing sight of those essentials can be costly. You heard me talk about the fundamentals earlier. This is the fundamental. It's not the hairy-fairy stuff about doing that test and this test and giving that treatment, this add-on, that add-on. That is the main stuff. And also we need to be reminded about what success means. It means, and that's something I invented that definition, because of practical implication, fulfilling individual couples' reproductive potential safely. She doesn't need to go to intensive care unit because she underwent careless ovarian stimulation, despite high ovarian reserve, ended up with severe hyperstimulation. She does not need to spend all of her money on one cycle, and that's where cost effectiveness comes. She does not need to be given treatment that undermine her potential when she is 28 and she's got to give us 50% or more per embryo transfer. And how about the cost? Would we expect her to spend all of the money that they have saved in one treatment cycle and then go borrowing more money? If there is no borrowing, she is left hung to dry and empty-handed. That is not cost effectiveness. The additional costs will come from where? From routine pre-treatment investigation and intervention, from ovarian stimulation that is either useless or extravagant, from extra sperm embryo selection tools that may not add values, from the adjuvants and add-ons. So these are the extensive battery of routine investigation. One of them is AMH. Fine, it may be justifying its existence, but for a patient whom you scan, you know she has polycystic ovaries. I don't think AMH will give you anything. But for other patients, it's helpful, and we use it in every day. Thrombophilia screen, why? Has she come to you with DVT? Has she come to you limping? Why? The thrombophilia screen. It's not indicated, neither acquired thrombophilia nor hereditary thrombophilia as a routine investigation, and it costs a fortune. Karyotyping, why? People are innocent until proven guilty. Why are you expecting her to have abnormal karyotype? However, if the patient is giving, she's, say, 30, and she has amenorrhea earlier on, and she had some blood tests to say she has premature ovarian insufficiency, you might find a mileage in trying to see whether she has fragile X or she has any abnormality in her karyotype. That's fine, but it will be academic. It does not affect what you do. Doing natural killer cells because they will kill her embryos, we know this story, fictitious. You might as well spend the money in something useful. Autoantibodies, people are interested, and they sometimes ask for anti-nuclear antibodies. Does anyone ask for that test? Total waste of time, totally irrelevant. Anti-phospholipid antibodies, totally irrelevant, waste of time and money. Or they do routine hormonal measurement for monitoring. Come and see me after 2 days of stimulation, I'll do a blood test to check your estrogen. Why? You already have a strategy that's safe. Estradiol will not add anything to this, will just waste time. She will take time off work if she works, or she will spend money on transport if she doesn't. To do DNA fragmentation tests, I hope we have killed that off. It doesn't add any value. It needs to be fragmented forever. Routine hormonal measurement, as I said. Additional expensive medication. Let's add a bit of steroids, because her body will kill the embryo. Total cocoland. Heparin. Why? Nobody knows. But I can guarantee you, not that I don't trust your answer, some of you in this room give patients heparin routinely. Correct? Yes? So I wasn't far off. Please, please, please stop. You're not doing your patient any favor. You're just depriving her of money and exposing her to something that could do harm than good. Patients who are prescribed Viagra, intravenous immunoglobulins, intralipid, DHA, aspirin, estradiol, using expensive gonadotropins, all gonadotropins. I always use the cheaper. And if I use recombinant FSH, if I can't get it the same price as the HMG, I'm not using it. And we are friends with the drug company, but they have like recombinant FSH-LH. For years, I say either you sell it at the price of HMG, ولا على رأي عادل إمام خللوه. It is very clear. Okay? Yeah. Then, unhelpful, unproven intervention. Endometrial scratching. We have been so naive to think that scratching the endometrium will make my grandmother pregnant. So naive. We can't even think. Okay. Acupuncture. Why? MC, where we select the sperm in some sophisticated way. Why? Where is the evidence? Unnecessary surgical sperm retrieval, where we say, oh, the ejaculate sperm is not good. Let's go for the testes. That's just anti-nature even. Embryo scope for incubator, when it came out, they say this is a smart incubator. If you put the embryos there, you get results, you get higher success rate. The Scandinavian did the largest study comparing natural incubation with the smart incubator. No added value. Embryo glue, insulting to intelligence. Because if the embryo does not have a life of its own that moves from 4 cells to 8 cells to 16 cells, even if you stable it, it will go nowhere. But still, people are willing to accept that mud. Error test, where you can decide where is the implantation window. Total waste of time. We asked that question in 2016 at the Upper Egypt conference of the guy who introduced it. And 10 years later, when eventually the accuracy assessment was done, it appears to be no better than tossing a coin, except tossing a coin is free. It will not cost you 1,300 pounds. Doing hysteroscopy routinely. Why? Because even uterus is innocent until proven otherwise. Why would you do hysteroscopy? If the patient does not have any menstrual issues, if your scan is clear, if she doesn't have symptoms, why should she pay for routine hysteroscopy and laparoscopy, etc.? Because the end result is she's running out of money. And then the main concern, she will be empty-handed. There is no baby. Not because she didn't have the money, because the money were misused. So it's all not about the test, it's about what add real value. What difference does it make? And on the term, what difference does it make? You will be, like I said, you see an ovary like this, you have all you need to know. This is a polycystic ovary. You don't need to be rocket scientist to make the diagnosis. This is will be having high ovarian reserve, will give me high ovarian response, and I need to be careful of ovarian hyperstimulation. All from that photo. You don't need any more investigation. Pre-IVF hysteroscopy. Yes, we all care about the seed as much as we care about the soil. But appearances matter. And if you have a scan like this, where you have a triple line endometrium, can anyone convince me or convince themselves that the hysteroscopy will give you anything extra to that very simple scan photo? Nothing. And if you have 3D scan, you get even more information, which is not uncommon currently. And if there is any suspicion there is polyp in the cavity, you can put some saline in the cavity. It costs so little compared with the cost of hysteroscopy and the complication. So even at simple 2D scan, you can tell that this endometrium is pathologically thin. And then you can go about it the way you like. You can get information about the embryology. You can get information about pathology, where the polyp is clearly situated, about the site of the submucosal myoma or the intramural pushing into the cavity, intrauterine adhesion from hysterosonography. So why should the patient pay for a hysteroscopy? Intrauterine adhesions that require good hysteroscopic surgeon. And this is a common sense test. When you see an endometrial image like this, would you really suspect any pathology in that cavity? Challenge me. Is there any pathology in that cavity? So why does it need hysteroscopy? Okay, and it tells you everything you need to know. Even a bit of physiology there, because it is mid-cycle, because there is a bit of cervical mucus, and it is clear. Nobody can tell me, oh, but we can't detect chronic endometritis. The endometrium that appears like this will never have chronic endometritis, because it will not be responsive to the hormones in the same way. Hysteroscopy is only indicated by vagina if ultrasound suggests possible intrauterine lesion. That should not be done routinely. Nobody will say, for these lesions, you should sit idle and do nothing. Hysteroscopy is the answer. There are still some areas that are controversial, and one of them is uterine septum. Should we resect uterine septum routinely? If you have a hysteroscope and you are really keen to make the return on investment, you will do it in everyone, of course. But if you look for the evidence, presence of a septum does not always mean bad news. How many patients that you see, they are multiparous, and by chance, when you are doing investigation for menorrhagia, you find they had a septum. So it did not interfere with their reproductive performance. And there are studies showed that out of 151 women underwent septum resection and 106 had expectant management. The follow-up for 46 months, the live birth rate was 53% in the resection group, 51% in the non-resected. International multi-center trial also showed that you really didn't get much. You get more from the expectant treatment than you get from removal. And you can see a picture here of a uterine septum. It didn't stop the implantation happening. It didn't stop the uterus growing. Most of women with septum do not suffer pregnancy loss. And we tend to forget something that's very important, but I doubt many people will take note of. If you look here, the proportion of miscarriages that are with abnormal embryonic karyotype is much, much higher than the one that with normal karyotype, meaning that the first 2 or 3, most of the time they are chromosomal abnormality. So attributing this to the septum unfairly and making your decision based on it is not something. And just because you have a hysteroscopy, you are good at it, it doesn't mean that you should. There is a very good ethical principle. Just because you can, it doesn't mean you should. Do we need to do antiphospholipid? I said earlier, and this done 25 years ago, this study, and showing that those who are positive or negative, they are not different in the live births. In fact, the positive antiphospholipid antibody on that meta-analysis have a bit higher live birth rate. Do we need to prescribe heparin for IVF patients? I feel like screaming. I'm not putting it symbolic. Because something does not have justification. Why do we do it? Yeah? Why? And I try to answer why use it. Because other people use it. Because patients request it, and I can't say no. Don't do medicine. Go and work in a supermarket. Yeah. I used it, and my patient got pregnant. It proves nothing. Patient get pregnant if you give them Polomint. Does it mean that Polomint can be prescribed as medical treatment? I read a paper and showed that it works. If you read everything if you believe everything you read, you need to revise your position. There is nothing else I can do. It's not an excuse for just doing things irrationally. If I don't do this and the treatment fails, patient will blame me. Then you have no conviction. Because on what ground would the patient blame you? I use them after the first cycle failed, but then because they help with success later. Where is the evidence? So inadequate knowledge or inadequate understanding are not good for medicine. So why use it? Also, some people will tell you doing something is better than nothing. No, that thing is not free. A course of heparin throughout the pregnancy, I can tell you that in Egypt it costs well over 10,000 pounds. Not many people have those extra 10,000 pounds for no added benefit. And again, it's all about the cost and the expenses. Conflict of interest should never stand in the way. We should always rely on evidence, and we should always read and read and read, but read carefully and wisely. We published this, which year? I can't remember. 2010 or 2015, that sperm DNA fragmentation is of no relevance to live birth. Still, people debate it. We know that DNA fragmentation is part of spermiogenesis. So it's not extra. And if you are excited about, ask the guy to give you a sperm test, and after 1 day of abstinence, definitely it will be low. Okay? So we need to just really throw our preconceived ideas out of the window and avoid the slippery slope, because one thing leads to another. And I always remind myself to make a habit of two things: to help, or at least don't do any harm. I say that to patients even before operating. I said, my pledge to you, if I can't make it better, I promise I will not make it worse. And that applies. Our guidelines always used in daily practice. Here is the ISHRA guidelines, talking about not giving 450 or 600 units doses, because above 300 is doubtful. Talks about not giving any endometrial injury or GCSF or intravenous intralipid, all in red, but still people use them. How about progesterone? In our area, in particular, in the Middle East, almost there is a consensus that patient must be given progesterone from every possible orifice. Isn't that true? Why? What is so special about our patient? The whole world, if you don't believe me, 80% of practitioners in Europe use 2 cyclogen suppositories, 800, that's all. But for us, we give tablets, we give intramuscular, we give, God only knows. DHA, every patient is being prescribed. It's been around for years. It has never made any impact other than give women who use it for a long time a mustache. It has been successful in that. Yeah? Ultra-long protocol. We used to do it for patients with endometriosis or adenomyosis. It is of little value. Gives the patient hot flushes, increase the use of gonadotrophins, and does not increase the outcome. If we stuck with old reviews, they were small number, but the revised Cochrane review suggests that is of no benefit. That was 3 years ago. And cryopreservation of semen before IVF, logistically you should. If the guy have fluctuating sperm, it would be good to freeze rather than being in a difficulty on the day. In azoospermic men, sometimes if we have doubt about finding sperm, we do the sperm retrieval ahead of time. But if he has obstructive azoospermia, it can be done on the same day, provided they can have someone to accompany them home at the end of the procedure. Hydrosalpinx before IVF, it should be removed. That's not controversial, or not removed, but at least disconnected in order not to affect ovarian blood supply. Mr. Chairman, ladies and gentlemen, IVF again is not rocket science, but it requires sound knowledge, adequate skills, and above all, professional and ethical attitude. Thank you very much. Before I forget, if I can can I have the slides again, please? Thank you. The last one. I said I have my turn of advertisement. If you like what you hear and you would like to see it in practice, we are having a course in the middle of November, and that will be online. So you feel free to join us by registration. And here is the, I was coerced into putting this slide by my team this morning. They sent me the slide that I can't find even. So here is the link, www.acuteaching.com, and you can book, and we welcome you online to get a tour of the premises, discussing cases, like practical cases, agreeing concept, discussing how we do things, and we will have some attending on site. Thank you very much.
Thank you very much, Professor Yaqub. I want to ask you about your review on using artificial intelligence in choosing good sperms and embryos. It's a new موديل جديد عندنا بالأردن.
Yes, no, I think, no, you don't remind me. I'm still scarred. I'm so sorry, Dr. Abi, because I can be clumsy sometimes. No, artificial intelligence is here to stay, and it will help us in doing things smartly. But my warning shot for now and for years to come, please don't mix the ends with the means. Artificial intelligence will never give a patient who is 44 1% extra, because the biology is limiting. Yes. But it will make us do things smarter. It will make us analyze big data bigger. Hopefully we can get a little bit of information to guide our practice, but it will not touch biology. If you look at 20 years of practice in the United States, patients who were 40 and above, their success rate has been a straight line. Patients who are under 35, it has been growing over the years. Why? Because their biology had that elasticity to benefit from technology. That will not change with artificial intelligence.
Thank you very much. Any question?
Yeah. Yes, Dr. The same.
Adenomyosis,
Yeah.
especially with generalized adenomyosis.
Yes.
I think probably there is a place for ultra-long protocols.
Again, you will do it because it is inherited. There is evidence? Absolutely not.
To decrease the size, because the adenomyosis, you have very large cavity.
Again,
and
I hear you. That is biological plausibility. There is not a shred of evidence to confirm what you're saying.
There is not enough data.
No.
to
People
say
have
yes
looked.
or no.
People have looked at adenomyosis, and they find, in particular, ultra-long did not alter the outcome. Yeah.
Doctor.
Yeah.
Thank you very much for your talk. I would like to hear your thoughts or opinion on the use of GnRH agonists and aromatase inhibitors in frozen cycle for people diagnosed with adenomyosis.
Again, you use it because you are making like a bit of deduction, but there is nothing to suggest. I never use letrozole for a frozen cycle, regardless of the pathology. It is either the programmed cycle where you use 8 milligrams of estradiol per day and scan the patient after 11, 12 days, and if the endometrium is above 7 millimeters, we prepare her for transfer by adding progesterone. But for adenomyosis, yes, we use in old days and endometriosis to add the long protocol, but in the face of evidence that showed there's no point torturing the patient with hot flashes and mood swing for 3 months before it, we don't use it.
Yeah. Thanks, Professor Khalaf, for the great presentation. Allow me to present Dr. Muhammad Hassan, our next speaker. He's a member of Royal College and a consultant gynecological surgery. He's the head of obstetrics and gynecology at the department at New Cairo Hospital in Egypt. He will talk to us about the prevalence of human papilloma virus among Egyptian women and its impact. Thank you, Doctor.
Good afternoon. Thanks, Mr. Chairman and ladies and gentlemen. Thank you so much for being with us up till now. And I would like to thank Dr. Mazen, Dr. Abir, and Dr. Maher for the generous invitation and being today with all of you. Thanks one more time. And I will try to take all of you away from the heavy meal of infertility and laparoscopic robotic surgeries to be in another side of the practice, which is the colposcopy and the risks, how to eliminate, not just reducing the risk of cervical cancer. When I came back from UK 2019 back to Egypt, I wondered why we don't have a screening program in Egypt regarding the cervical cancer. And from that point, we decided, me and some friends who are really keen about improving the practice, we are very keen to establish a screening program, a national screening program in Egypt. We had a lot of conflicts, a lot of obstacles, but fortunately, we did it successfully, and this is my journey through establishing the cervical screening program in Egypt. By the way, as an intro, the cervical cancer is still a huge burden worldwide, and up to 600,000 cases developed every year. And this is not only in developing countries, but also in developed ones. And cervical cancer is preventable disease through early detection and now even by vaccination. Can you imagine that it's a preventable disease? No one can guarantee that he will never have a leukemia, for example, one day. But women can guarantee that cervical cancer will never happen to them once they follow the screening system and taking the vaccination. And it's important to start or establish a system that has wide coverage to protect a woman. And the cervical cancer burden is high among women. It's not only among women and their fertility option, but it's also about the country. Every country is taking a lot of effort, money, and expenses to treat women with cervical cancer. The surprise is even with the best treatment plans, the recovery is not guaranteed. Cervical cancer is still the second most common cancer among women aged from 15, which is a very strange number, to 44. I remembered a case 6 months ago in Egypt. She was 24 and she just married 2 years back. She came with a mass in a cervix, and this mass, I examined her, and the surgical staging revealed stage 2A. Unfortunately, the plan was to preserve her fertility with chemoradiation, and she didn't respond well, and we had a surgery after a radiation, which was miserable, and then the patient is unable to fight, and she did. So I'm not so much black mood guy, but this cancer is a very aggressive, even in early stages, so we should be very keen about that. And there is another point also that is associated with the main causative agent for cervical cancer, the HPV infection, which is not only oncogenic strains that may lead to a cervical cancer, but they are also genital warts that is really annoying patients and really affecting their performance. So we need to think twice. Are we have to go to eliminate the HPV if possible? By the way, the HPV infection is considered the most common viral sexually transmitted disease worldwide. In Egypt, the HPV prevalence in women, nobody knows before What is the prevalence in Egypt? Because this issue was not that necessarily. So, but in 2010, there was a study conducted by 3 major universities in Egypt, Cairo, Ain Shams, and Alexandria University. And in a randomized trial, they discovered that the incidence is about 10% among randomized population. In 2020, I was honored to conduct another study using the new LBC, liquid-based cytology technique, to identify the incidence, the new incidence of HPV in Egypt. We used to screen randomly women from different age groups, different geographic backgrounds, different socioeconomic classes, and we realized that around 14% of them, asymptomatic women, were positive HPV. And this is one of the most important things in screening tests. We are going to screen asymptomatic patients, not symptomatic one. So the number seems to be not that high, 14%. But if you calculate the number, okay, we have around 65 million women in Egypt. So in the age group between 25 to, for example, 55, they are around 30 millions. So I think 14% from 30 millions, it's a huge number, okay? That's fine. This is the study, and it was done by the Egyptian Society of Colposcopy and Cervical Pathology, and it has a very good reputation worldwide. So, costly burden of HPV-associated cancers, not only the cervical cancer. The HPV seems also to affect oropharyngeal tumors and anal cancer, either in men or women, as well as benign carcinoma in men as well. So it's not only a virus related to a cervical cancer. The human papilloma virus, by the way, is a very weak organism. Imagine that there is no viremia with HPV. That's why there are no antigens or antibodies can be detected in the body of the patient. Once the HPV is introducing in the bloodstream, it will be destructed. So it's very weak. And one of the best treatments ever for HPV is a good immunity. So the body is fashioned to eliminate it from the body, by a good immunity. And this is one of the best strategies to treat the HPV. It can be there for many years before start doing dyskaryosis and cellular liver changes, and then before being invasive cancer. The HPV infection seems to be eliminated from a good immunity body in 2 years maximum. After that, it turns into a chronic status. And then the work over the cells started. Low-grade dyskaryosis, then the high-grade dyskaryosis, and this is the stage before invasive cancer. So God give us almost 10 years to catch it and to treat women before invasive cancer. If you would like to lose the time, it's your problem. And again, one of the major obstacles in discussing such scenario with a patient is to tell her about the root of infection. Because it's believed that HPV infection is sexually transmitted disease. We have other routes, non-sexual routes of transmission, like transvaginal probes, like some laser machines, I don't know, underwears, hand-to-hand contact sometimes, but still it's a sexual route. It's about 99.5 sexually transmitted disease. The story started very early in 1941 with Papa Nicolau, who invents the pap smear. And then the story is developed, and in 2020, we discovered that the liquid-based cytology is considered the most accurate screening test, and it gives us a very important point that we can examine either HPV and the cells as well. So what are the most international famous recommendations regarding the vaccines? Because this is very critical. If you have a budget and you would like to prevent the cervical cancer and HPV, would you like to invest this budget in vaccination program or in screening program? Please don't mix. If the patient is vaccinated or a woman is vaccinated, it doesn't mean that she is not in need for screening, okay? So which is which? Actually, the vaccines are recommended in developed countries since 2008 in UK, and it's recommended from the age of 9 in all females in different schools in UK, and it can be given either in 2 doses or 3 doses. Also, the recommendations for HPV vaccination of women with cervical precancerous lesion, I mean dysplastic cells, proven dysplastic cells, it's recommended that it may help to prevent further deterioration of cells. So the efficacy of vaccination, it seems it's very effective, up to 100% efficacy to protect women against the viral infection. So we believe that the prevention should be started from the vaccination program, and that's what's happening exactly in Egypt's cervical screening national program. The cervical screening program itself, it started 1970 in USA and UK, and it started from 25 years up to 65 years in all women. I think Dr. Muayyad showed us in the very early today in his very respectable presentation the screening program according to the age groups. It seems to be every 3 years between age of 25 to 49, and then from 50 to 65 every 5 years. If the woman in the last 2 tests are completely free, she can be discharged safely from the program. The LBC, again, is giving us a very important advantage that by one test we can either examine the HPV positive or negative presence, and we can examine the cells as well. The cytological results seems in the British Society of Colposcopy and Cervical Pathology, they use the terms of inadequate if the test is not clearly providing data, or a low-grade dyskaryosis, borderline dyskaryosis, or high-grade dyskaryosis. These terms are translated in low-grade squamous intraepithelial lesions, or atypical squamous undermined significant cells, or high-grade cells of risk. So it depends on the nature of cellular atypia or dysplasia. The treatment plan will be established after that. How to manage? Just to summarize this plan, I can say, if you have inadequate results, please repeat the test 3 months after and wait for the new results. If you have a low-grade dyskaryosis, those kind of patients can be easily followed up, okay? No need to touch them. Give them some immune boosters and wait, and re-examine after a year. If the patient showed moderate to high-risk dyskaryosis, now we have to take a step. What kind of steps? We can treat either by electrosurgery, or by cryosurgery. Let's see. The most important thing is to refer the patient after dysplasia to a colposcopy, the missed practice in Egypt. I don't know in the MENA region, but in Egypt it was a missed practice for many years. Despite it's very simple, all you need to know how to identify the transformation zone. I discovered that most of my junior trainees, they are unable to identify the transformation zone where the cells are transforming from columnar epithelium intracervical to be stratified squamous epithelium in ectocervix. This critical zone of transformation of cells should be clearly examined. And please notice that most of my junior trainees, when you just insert the casco speculum and find the cervix with any more reddish area, he or she supposed this is the transformation zone, which absolutely wrong. The transformation zone is the area between the red lips and the dotted line. It's an area and should be fully visible before examination. What kind of examination? Simply, I can use the acetic acid, 5%, just apply it on the transformation zone. If you find it like more whitish, you can assume that we have some pathology here. And we can clearly demarcate the transformation zone by using Lugel's iodine, which will describe in details the boundaries and the borders of transformation zone. Then you will be able to clearly examine, even taking a biopsy, like a bunch biopsy. The bunch biopsy is critical because sometimes it's very confusing. I remember a very important sentence. The colposcopy is subjective. It's not objective. So what I can say, if I diagnose a lesion, a C2-white lesion, I may say it's CIN1. One of my colleagues, he may say, no, it looks like CIN2. So it's completely subjective. So the confirming diagnosis with bunch biopsy will be really important, and it's a very easy practice. By the way, it requires even no anesthesia, local anesthesia even. Okay, and then the treatment can be done either by LEDS, large loop excision of the transformation zone in high risk or high grade lesions, CIN2 or 3. And in CIN1, if the patient prefers to have a treatment, we can offer her simplest method of treatment with cryotherapy. After all of that, I think in Egypt, we tried to have a national cervical screening program to follow the international strategy of the WHO for elimination of cervical cancer by 2030. Trying to give the women in Egypt and the girls as well a vaccine as early as possible before starting their sexual life. And globally, the HPV vaccine introduced into many countries, and by year 2023, almost 150 countries are using routinely the vaccinations between the age of 9, 10 to 12 years. Many Arab countries in the MENA regions as well, they used to follow the vaccination program, like Abu Dhabi, starting from 2008, ending by 2023, Bahrain, Qatar, Kuwait, and UAE as a governmental school-based vaccination program. In 2023, we were able to establish a screening program successfully, alhamdulillah, and we used these messages on time. I will be on time. We used these messages to convince people about the vaccination because it was really difficult to change the mindset of people in Egypt. raise the risk of HPV infections, the importance of vaccine, the importance of screening program as well, and keep it simple. It should be effective, safe, recommended plan to protect all our women. In Egypt, we as an Egyptian Society of Colposcopy and Cervical Pathology, I am a founder and the treasurer of this society, which is legalized and accredited from the British Society of Colposcopy and Cervical Pathology and International Federation of Colposcopy. Under the patronage of the President and Prime Minister, we successfully established 100 million women health campaign, which is working starting from 2023. And our dream in the ESCCP becomes true, and we successfully vaccinated 1.2 million women in 2024, which is really, I think, is a great achievement in our practice. I'm very happy that I shared our experience in Egypt with all of you today. Thank you so much for your time. And if we could prevent cervical cancer, would you do that? Thank you so much.
Thank you, Dr. Muhammad, for your presentation. And we congratulate you for the success that you had in
Thank you.
our sister Egypt. Now, any questions? Dr. Falah.
Thank you, Dr. Muhammad. Thank you. We in Jordan, we are around 10.5, 11 million.
Yes.
We have a good registry of cervical cancer, and we have a total of 62 cases every year of cervical cancer.
62.
So when you give me the number of 275,000, I think that's overestimated. I cannot take it as a real number. And we have to remember that a lot of us, or most of us, we are manipulated by the drug companies who sponsor some of our work and some of our travels and some of our activities. I think there is no harm of doing vaccination. There is no harm. Make it easy for everyone, but the price of the vaccine is very high. It is $500 for the whole vaccination. In Egypt, I know 15% of the people, they have hepatitis C, which is more lethal than cervical cancer. And I will question mark, or really question that you have in Egypt have 270,000. If you double Egypt is 10 times as much Jordan, it's probably around 600 cases, not 270,000 cases. So what do you think of it? You know, there is no harm of giving vaccine for the people who can afford it. And we cannot make what the Gulf do because they have a lot of money. A lot of money.
Yes.
But they have so many priorities for Egypt and Jordan, the poor countries. Sorry.
No, it's true. Because we struggled a lot to establish this system. But I thank you so much for raising up about this point, particularly about the expenses. Now, let me answer the question by two answers. The first one is regarding the number of cervical cancer patients in Egypt. Actually, we have some problems in documentations. Now, simply, we can retrieve information from big parties like universities and institutes, but actually, we have a parallel medical community in Egypt, which is the private sector. There are no data from private sector, and we saw a lot of cases in the private sector. Number two, we have about 50% of patients of HCV in Egypt, but this is prior to 2012, because successfully 90% of patients, up to 95% of patients of HCV infection in Egypt were already treated. So it's not anymore a priority in health care system in Egypt. The third point is about the vaccine expenses. We were very lucky that we have some supporters, NGOs, whom are able to provide us with a great support so that we can provide most of women with vaccination with a limited price. So this is the game. In Egypt, the dose is 750, Egyptian
500
pounds.
US dollars.
Egyptian pounds. In dollars?
500 US dollars. I'm telling you, 500 US dollars here.
Anyway, I have a question.
I will evaluate it on calculator. Yes.
And the other,
This is the one dose.
Okay.
Oh, there is no comparison.
And
There is no comparison.
and the other point I want really to mention it on colposcopy, there is no real colposcopy without doing associated endocervical curettage. Okay? Endocervical curettage, not only the ectocervix and the transformation zone, you have to do endocervical curettage, bicoverca correct or whatever.
I agree 100% about the endocervical
Of them,
testing.
they are endocervical.
Yeah, I agree 100% about endocervical testing. In some situations, particularly in age of women more than 40, it's highly recommended to do a curettage particularly. Thank you.
I have a simple question. We had a problem when we first presented the vaccine to our patients
Community,
or to their parents. When we knew about a vaccine, a sexually transmitted infection, people were sensitive about it. And then we started doing it like a vaccine for a virus that causes cancer.
Exactly.
Without mentioning the sexually transmitted way of it. Did you have such a problem with the Egyptian patients, families?
100%. احنا عندنا قناعة كده في مصر ان احنا شعب متدين بطبعه. فما كانش عندنا يعني we have no way to deal and to convince patients and people, particularly parents, to give her children this HPV vaccination. But what we did exactly, we played the game on two levels. Personal one-to-one doctor-patient relationships, and we conducted different social campaigns and invading the media to convince the community about the importance of vaccination, and we played the game that it prevent multiple types of cancers, not only cervical.
Thank you very much.
Thank you.
It gives me great pleasure to introduce my friend, Professor Nadim Al-Jarrah. He's a consultant endocrinologist and fellow of the American College of Endocrinology. He's the head of the internal medicine department at Specialty Hospital, and he's a lecturer in Mu'ta University, internal medicine department. And he's the head of scientific committee of the Jordanian Society for the Care of Diabetes. And he's going to talk about a new era of diabetes management, of obesity management, not diabetes.
Okay. مساء الخير جميعا. دكتور شوقي، دكتور عمر، يسعد مساكم. It's a great pleasure and honor to be in this great Congress. Dr. Abir, Dr. Mazen, Dr. Maher, and your group, congratulations for conducting this Congress. So a topic of ours to talk about, I will shed light on it in over around 20 minutes. Let me start with this. This is my own perspective. I believe the objective of obesity treatment is to gain health by reducing body weight. And by reducing body weight, I mean is to reduce the fat mass and to preserve the skeletal muscle. If we lose weight, including skeletal mass, this is a very unsuccessful job. The prevalence of obesity at a glance, يعني بالعامية بداش حكي زي ما بيحكوا. It is all over the world. Women more than men, all the areas are affected. In our area, in the Middle East, we are talking about prevalence between more than 20, of course. It's up to more than 30 body mass index, including both genders. The World Obesity Atlas 2025, sad news. They announced that 2/3 of countries worldwide, they don't have any national policy to face the pandemic of obesity. Around 2 million premature deaths of non-communicable diseases by diabetes, coronary artery disease, strokes, which are, of course, the side effects of obesity, are taking place 2 million annually because we are unable to face the pandemic of obesity. Obesity, dear colleagues, is a disease. It's not a feature, it's a disease. And as you know, the definition of health internationally, it's a state of complete physical, mental, and social well-being. It's not merely the absence of disease alone. So obesity has all the criteria or the features of being a disease, starting from the impairment of normal function. You just name it: appetite dysregulation, abnormal energy balance, endocrine dysfunction, and infertility, and this belongs to this Congress, and muscle is the new terminology instead of NAFLD. It has the characteristic signs or symptoms, and you can see the features of the symptoms and signs, and ending with complications and comorbidity. At the top of the list is type 2 diabetes and cardiovascular diseases, strokes, joints, and polycystic ovary syndrome. So it is a disease, and we have to address it as a disease. All the societies related to metabolic health, obesity, and diabetes, they have several definitions for obesity, and I will quote the definition of the Royal College of Physicians. It says that obesity is not a lifestyle choice caused by individual greed, but a disease caused by health inequalities, genetic influences, and social factors. So this is a call not to stigmatize our patients. If you take these four definitions all together and extrapolate one word from each, this is the summary. This is my summary, okay? It is a disease. It's a chronic disease. It is a progressive disease. It doesn't stop. It is a relapsing disease. There is no cure, okay, unless man rahamahu rabbi. But it is a relapsing disease, and here we need some tools to prevent the relapsing of obesity. It has a lot of complications, and it creates a stigma, a psychological trauma for the patients. BMI is a very crude, very initial way to assess obesity in the clinic, okay? You need the height and the weight, and you do the equation, and we have the different classes from class 1 up to class 4. And by the way, there is difference بالclassification للBMI according to the race, So it's not acceptable anymore to use BMI alone to diagnose this complicated disease. And by the way, if you have the choice to choose a BMI for yourself, خليني أغششكم, choose 22. Because you can see the 22 here, it is just touching the line of unity. So it is the least with all-cause mortalities, the BMI of 22. Now, less is more and high is high. Less body weight, it creates morbidities. Unfortunately, any BMI less than 18, less than 16, it creates disease, morbidities. And the high BMI, of course, will create all the diseases which we know. Now, because of this, it's not recommended to use BMI alone. It is recommended in the clinic to use the waist circumference. And the most accepted, encouraged parameter to be calculated now is the waist-height ratio. You need a meter, فقط. You measure the waist and the height, and you take the ratio. Normally, it should be less than 0.48. Anything more indicates there is intra-abdominal adipose tissue. And if you are in academia center, you can do the DEXA scan, CT, MRI to assess the adipose tissue in different parts of the body. Now, the BMI, there is always a very old data showing that the BMI, the higher the BMI, the less the chance of survival. For example, those with normal BMI here, okay, 80% chance of reaching the age of 70. If the BMI 40 and more, only 50% chance to reach the age of 70. Dear colleagues, obesity is a burden. It's a burden on every cell in our body, on every organ in our body, and every joint in the lower limbs. So it's a huge burden, okay? And these are the complications of this disease. Those related to your kind cells are, of course, polycystic ovary syndrome, subfertility, infertility, gestational diabetes, just name it, let alone the psychological part of the problem. The metabolic issue, we are talking about the muscle, the liver disease, diabetes, prediabetes, dyslipidemia, let alone depression and the psychological aspects, the heart, cardiovascular. So all of these are affected. This is why I'm saying it's a huge burden on the body. The good news that if we lose weight, okay, there is a benefit. And this is a very solid data showing that most patients with obesity can achieve significant weight loss and health benefits and improved quality of life. For instance, if patients lose, and by the way, if you want to assess the success of losing weight, do it by percentage. Okay, calculate it by percentage, مش 10 كيلو مثلا. Okay, by percentage is the one which is used in the data. If patients lose, for instance, 20%, they might have type 2 diabetes remission. I have patients, مش patient, patients were on insulin for treatment for diabetes. They did a kind of weight loss by either bariatric surgery or GLP-1 receptor analogs, and they are now off insulin. They are not using insulin. So this is a very solid data showing how much we lose in percentage and how it's the benefit we get from this weight loss. And this is the same data, but in a picture. And we have, I like this statement that we have to concentrate on complication-centric care for our patients, okay? And all of these will benefit, especially the systemic inflammation. Obesity, dear colleagues, is a very inflammatory condition for the body. For the sake of this Congress, again, we are talking about polycystic ovary syndrome, gestational diabetes, and so on. So obesity, dear colleagues, is not simply due to an individual's choice or lack of willpower. It's not like this. It's many factors. They play a role together, hand in hand, to cause the disease of obesity. I'm not saying that the person is not responsible for what he eats or what she eats, but it's not only eating a lot, I'll become obese. Genetics. There is a very strong data from the Scandinavian showed that adopted children, their body size will follow their biological parents, not the adoptees. Okay? And so the genetics play a role in this situation. Now, we have a problem in the management of obesity that when we lose weight, 10%, 12%, and more from the initial weight, the body will kick off, the brain will start working hardly to bring back the weight which we lose. This is the problem of maintenance. يعني مرات الbeginning بتكون أسهل من المينتنس, and this has a play with the hormones. And the most important hormone is ghrelin. Once we lose 12% and more of our body weight, there is a very well-known data, ghrelin will become doubled and doubled, trying to bring back the weight which we lost. And here comes the role of the pharmacological treatment to maintain, to help people to maintain the weight which they lost. Obesity remains underdiagnosed and undertreated. Okay, this is a kind of suggestion by the Canadian Adult Obesity Clinical Practice Guidelines, how to walk with your patient towards putting the plan of treatment, how to talk with them, and so on. So the foundation for the treatment of this disease, of course, this is the foundation, lifestyle. And I always tell my patients, okay, نأكل أقل نتحرك أكثر. طبعا this is a very naive simple statement, but يعني this is the foundation. Then we will go up to behavioral modification, pharmacotherapy, and surgery. The pharmacotherapy nowadays, we are talking about 5 agents approved by the US FDA to treat obesity. The most popular on the planet Earth now are the GLP-1 receptor agonists. So let us move on. There is a role of metabolic surgery, of course. Now, the second and last part of my talk, dear friends, Chairman, I will talk about data. We started to know about the GLP-1 receptor agonists in بيفيدوا weight loss since around 10 years, when we had liraglutide. This was the first agent خلال دراسة السكيل obesity study, which showed that if we use an agent called liraglutide, 3 milligram versus placebo with diet and exercise, okay, for patients with, عم نحكي عن around 4,000 patients, more than 18, BMI more than 30, okay, either they have pre-diabetes or without pre-diabetes. So a group took liraglutide 3 milligram and the other arm took placebo, and there was a huge difference between the two arms. This was the beginning of our knowing that the GLP-1 receptor agonists, they induce weight in 56 weeks, placebo versus liraglutide. With statistical significance, side effects, yes, there are side effects. وهذا موضوع بنحكي عنه كثير. Social media now, they are exaggerating the side effects of GLP-1 receptor, but yes, there are side effects, and we have to talk about them with our patients before initiating this kind of treatment. The most common are GIT side effects: nausea, constipation, diarrhea, bloating, or gallbladder disease, and so on. Now, the semaglutide is a new generation of the GLP-1 receptor agonist. The first semaglutide, up to 1 milligram, was used as anti-diabetes agent. Now we are talking about semaglutide of 2.4 milligram once weekly as a weight-lowering agent. It's a human GLP-1 analog. The homology native GLP-1, it's 94%. The half-life, 1 week. This is why we are using it once weekly. How come? Why this agent works for 1 week? Because of 3 steps, 1, 2, and 3. This was the modification, the GLP-1 molecule, which render it to be a very, very long-acting half-life of 1 week, and we are using it once weekly. How does it act? It acts in the brain at the centers for the appetite and craving for food, and at the stomach, it causes a dilatation of the stomach, so the patient will not be able to receive more food, and this will create a kind of craving, and this will end by reduced energy intake. And now we are ongoing data showing more benefits on the adipose tissue itself. So the benefits for the semaglutide, better craving control, okay, over 104 weeks, craving control was there, positive mood, I assume by losing the weight, the craving for savory and craving for sweet was controlled. The second methodology, or let us say, or way of action, reduced hunger and increased feelings of fullness. The hunger is reduced, the fullness is increased, satiety is increased, and prospective food consumption is reduced. So all of this will help patients to change their lifestyle and to start losing weight. And if we study the energy intake compared to placebo, there is a 35% reduction energy intake. Lastly, there is a huge program about semaglutide 2.4. It's called the STEP program. The aim of the STEP program is to study the effect of the 2.4 semaglutide on weight loss. We have step 1 up to step 10. And every study has its own characters. For instance, step 8 was comparing semaglutide 2.4 versus liraglutide 3 milligram, and it showed that semaglutide was much, much potent than liraglutide in osteoarthritis and so on. In heart failure, it was positive, and those preserved ejection fraction and diabetes. And I will concentrate on select CV outcome trial. But let me give you a very quick review about the results of the program, select program as a whole. It showed dark blue, it goes with semaglutide 2.4, and this is for placebo. And as you can see in all the studies in the STEP program, there is a weight loss across the STEP program, and those who lost more than 10%, which is a very good amount of weight loss, it was at a glance, you can appreciate, we are talking about around 70 to 80%, more than 10% weight loss versus placebo. Semaglutide versus 2.4 versus placebo. It's beneficial for the heart, it's beneficial for the systolic blood pressure. You can appreciate the reduction in the systolic blood pressure and the diastolic blood pressure reduction versus placebo, and these are the STEP studies in the STEP program. CRP, as you know, it's a marker for inflammation, and as I mentioned, obesity is an inflammatory state. And yes, again, there was significant reduction in the CRP in step 1, 3, and 2. And Okarrer in the STEP program includes at least 8 studies, let alone the heart studies and the diabetes study. Of course, it reduces HbA1c because originally it is an anti-hyperglycemic agent. And by inducing 10% and more of weight loss, of course, this will control glycemia. Yes, there are side effects. When we talk about nausea, okay, 40% they had mild nausea, diarrhea, عم نحكي عن 27%, vomiting, constipation. So yes, the GIT side effects are well known. What I do when I start this treatment for my patients, I discuss with them, and one of the relatives, يفضل يكون موجود, that please notice that in the first few weeks you will experience a kind of nausea or GIT side effects. Now, in spite of doing a good job in reducing cardiovascular diseases over the last 2 decades because of statins, aspirin, and others, still now in 2020, the cardiovascular mortality had cardiovascular mortality related to obesity was still very high. It was 3-fold, okay, compared to the overall cardiovascular mortality. So if we want to do a better job reducing the cardiovascular mortality, we have to work on obesity. And why obesity causes cardiovascular diseases? Because it's a systemic inflammation. And this will affect the endothelium, the liver, the muscles, and will reduce the insulin production. And because of this, we have this study. We call it the SELECT trial. It's a very important study. It's a cardiovascular outcome study. What does it mean? This study was done to prove that the semaglutide 2.4 was non-inferior label positive regarding the cardiovascular diseases. So this is the methodology. We are talking about 41 countries, 800 sites, BMI more than equal 27, age more than equal 45. They have established cardiovascular disease, but no diabetes. Okarrer, no diabetes. Patients were on placebo plus standard of care, or الARM active, semaglutide 2.4, with once weekly with standard of care. And please notice, standard of care, and these people are taking the full attention regarding diet, exercise, and so on. The primary endpoints were the three-point MACE, and the confirmatory was 5-point MACE. So these are the results. There was a 20% reduction risk of major adverse cardiovascular events. All the components, the 3-point MACE, were reduced with very high superiority, very narrow confidence interval, less than 1, showing that semaglutide 2.4 was strongly positive to reduce the 3-point MACE regarding the cardiovascular diseases compared to placebo. And because of this, immediately, the next year, the European Society of Cardiology did this announcement. Once weekly semaglutide 2.4 is the only weight loss intervention with proven efficacy in patients with established cardiovascular disease without type 2 diabetes. What does it mean? It means the results of the SELECT study, as simple as this. Lastly, this study is the STEER study. It is a real-life study. قارنوا semaglutide 2.4 versus twin-incretin. What is twin-incretin? It is a GLP-1 with GIP in the same device.